Hello, everyone. I'm Dr. Lori Shutter from the University of Pittsburgh and UPMC Healthcare System in Pittsburgh, Pennsylvania. I want to thank the organizers of World Coma Day for allowing me to present on performing the neurologic exam in assessment of comatose patients. I do have some disclosures. I have funding from the NIH. Also, I really like physiology and I like monitoring the brain, but I'm not going there today. I'm actually just going to be talking about the clinical exam and how we can use it in patients in low responsive states. When we think of monitoring patients, many times we get caught up as intensivists or people involved in managing coma in the tools, in imaging, in advanced electrophysiology, and think this gives us information. But I'm going to try to bring us back to the actual clinical exam and simple things we can do at bedside to help assess a patient's level of consciousness. As a reminder to this group, defining levels of consciousness is very important, and we are focusing on the lower levels of consciousness: coma, unresponsive wakefulness, which used to be called vegetative state, and minimally conscious states. We're going to try to talk about how we can use our exam to separate these different states. So when we go to assess level of consciousness, there are reasons why we may misdiagnose patients. There's usually a lack of practical measures to do serial assessments. The patients have fluctuating arousal, fluctuating consciousness, and we may not optimize the situation for the patient to do their best when we do these exams. They are subject to our own abilities, our time limitations, and our preferences. So there may be issues that we are not allowing the patients to have their best responses. The Glasgow Coma Scale is probably one of the best known scores, but one of the limitations with it is that a single GCS score can represent numerous different disorders of consciousness states. So it doesn't really help us differentiate levels of consciousness. The full outline of unresponsiveness score actually helps improve that because it allows us to look at brainstem reflexes, but it doesn't really look at behaviors associated with minimally conscious states. And then there's the coma recovery scale that's used by our rehab colleagues. And it's not really used much in the ICU setting, but maybe we should be looking at it in that environment to help us identify patients at different levels of consciousness earlier in their hospital course. So briefly on the force score, first reported in 2005, the graphic here shows you the different components of the test, and you notice that there is a lot more assessment of brainstem reflexes when compared to the Glasgow Coma Scale, as well as looking at respiratory patterns. In 2011, Elko Vijics and his group actually looked at the ability of the force score to predict in-hospital or 3-month mortality. They looked at 381 patients and found that force scores less than or equal to 1 were associated with an 84% chance of in-hospital or 3-month mortality, compared to only 44% of those patients who had force scores greater than 1. And this is probably a reflection of the loss of brainstem reflexes. Now, the coma recovery score is actually has capabilities to help us differentiate patients in minimally conscious state from those in an unresponsive wakefulness state. It has good inter-rater and test-retest reliability. It is used by our rehab colleagues, but it is a tool that we might be able to use more in the ICU if we become familiar with it. So let's talk about how to actually assess our patients. It often just starts with observation. What's the patient's spontaneous movements? What are their breathing patterns? What kind of reflexes are they showing? What are the family members, caregivers, and staff who are there daily at bedside saying about the patient's responsiveness. That should be brought into consideration. We should optimize the clinical setting and the patient's arousal so we can actually try to look for preserved cognitive functioning. Taper off sedating meds, treat subclinical seizures. When you assess the patients, make sure that it's a distraction-free or minimal distractions in the environment. Adapt your command following trials to the behaviors the patient has the physical ability to do. If they have trauma to their right arm or their stroke involving their right side, they may not be able to use that arm. So maybe you need to focus on leg movements. Maybe you need to focus on facial responses. Also, your stimuli need to be variable, auditory stimuli, visual stimuli, using different things to try to get a response. And then assessing the patients serially. Use the same reliable tools, do it on a consistent basis, and try to obtain quantitative assessments for all of these actions. I'm going to briefly talk about pupillometry. The NPI is an algorithm that allows us to take out subjectivity from looking at pupils. It looks at the speed of responsiveness and the size, and usually a score greater than 3 is considered in the normal boundary or a brisk reflex, and less than 3 is lower. Now, this is often used by intensivists to help look for neurologic worsening. Classic example here with the patient who has normal NPIs, and then the nurse will suddenly bring this to you where the NPI has fallen down below 3. Now, this may trigger imaging or looking at EEG or doing something else to try to assess the patient's responsiveness. But maybe it has more uses beyond just measuring or giving being a surrogate for ICP. In this study, it was a prospective international study looking at NPI versus standard pupillary light reflexes, and they tried to predict unfavorable neurologic outcome, and this was after cardiac arrest. The assessments were recorded simultaneously on days 1 to 3 or in parallel, closely together. And the primary endpoint was would the NPI or the light reflex help correlate and predict 3-month outcomes based on the CPC. And it was dichotomized as a CPC of 1 to 2, which was full recovery or moderate disability, versus a CPC of 3 to 5, being severe disability, unresponsive wakefulness, or death. And what they found is that patients who had NPIs less than or equal to 2, and this was in 456 patients, that this was highly predictive of unfavorable outcomes. And if you added this to somatosensory evoked testing, you actually had higher sensitivities with a comparable specificity of 100%. So using this tool to actually help predict outcome may be another option for us. And just looking at the graph, the light orange bars are the favorable outcomes, the CPCs of 1 to 2, and you can see the separation at all 3 time points or days of measuring. So another way to use a common bedside tool. Looking at eye movements is also very important, and we may not look as deeply as we should. We typically look at visual pursuit, voluntary eye movements, blink to threat, but maybe smooth pursuit movements will actually give us more insight in a patient's level of responsiveness. You can use a mirror. And that really tends to drive somebody whether they will track because they are focusing on their own face, or you can use the standard using your finger and having them try to follow it. But a mirror may be a better tool and give you more insight. Now, this study was actually done in 18 patients with chronic disorders of consciousness, and they used a computerized infrared eye tracker system, giving stimuli that moved on a monitor, and they looked at how often the patient actually fixated on the target. The 18 patients, there were 9 in vegetative states and 9 in unresponsive wakefulness states. This is the setup, a red circle versus a colored picture, and the top graph is the normal controls, and you can see how they clearly track the stimuli. The middle box are patients that were minimally conscious, and you see better tracking. And then the bottom box were those patients that are unresponsive wakefulness, where there doesn't seem to be a real tracking of the stimuli. And you can see the separation between the patients. The dashed line is would be just random value for eye gaze. And there is clearly this separation between the groups. And it actually, when they looked at it in more detail, the minimally conscious states patients may have responded more to the picture than the actual red dot. So there was a difference between groups that you can see in the graph on the top, and then the lower graph actually looked at the duration of target fixation, and you can see this separation. This device has gone on. There's more human-computer interfaces and tasks that are being developed where patients will be, words will be spoken to them, sentences, pictures will be shown, they'll be given yes and no questions or asked to identify a number, and you actually monitor where the patient looks and do they hold the gaze for 2 seconds. So the application runs and there is a dot that shows up that demonstrates where they are looking. And in this example, they actually reported the ability, or they reported that 6 out of 10 patients had conscious performance. And what's really interesting is if you look at P4 here, the GCS was very low in this patient, but they demonstrated consciousness, the green circles, at the second highest level. And as they further assessed this patient, it turned out they were locked in. So this may be a tool that we could use as tracking devices become smaller to help us identify patients that do have some arousal. And it may be as effective as advanced electrophysiology, that we could actually ask simple yes/no questions and see if the patient will look at it and allow us to separate out patients that may be more aroused, that may have some level of consciousness. Another interesting assessment is using olfactory sniffing signals. Actually, if you give an olfactory stimulus, then as the patient sniffs, there's a difference in nasal airflow, and you can measure that. And this study had 73 sessions conducted in 31 patients in a minimally conscious state and 24 patients in an unresponsive wakefulness state. And they looked at both the level of consciousness of the patient and the sniff response. And you can see this separation here, that patients in a minimally conscious state had a more robust sniff response than patients who were in a unresponsive wakefulness state. So another tool that we may be able to use, and this is measured just using nasal cannula, and it's linked to a spirometer that converts airflow into voltage, and then that's amplified to get a sense of the sniff response. Another thing that's been reported recently is spontaneous eye blinking, and just counting the number of eye blinks may actually allow us to separate out patients. This was in 10 patients who were in an unresponsive wakefulness state and 14 in minimally conscious state, and they would look at eye blinks over a 2-minute time period and showed a correlation with the Glasgow Coma Recovery Scale. And it actually seemed to correlate well. And a final thing I want to point out is just using EEG in a controlled way. In this study that we performed at Pittsburgh, one single patient who the family swore was responsive, we looked at her standard EEG and we did very specialized testing. We had a clap response, we applied nail bed pressure, and we had her dad give exams. And we clearly saw that when her dad spoke to her, she showed more responsiveness and a faster responsiveness. This patient ultimately progressed to actually becoming aroused and becoming conscious and being able to follow commands, and ultimately went home. She had been a post-anoxic patient that people thought she had no level of responsiveness, but she proved them wrong. So in summary, we need to spend time at the bedside. We need to examine people carefully. We need to individualize our targets, and we need to use different tools. So be a little more creative at bedside, and let's see if we can do better jobs of assessing our patients just from the basic skill sets of examining a patient. So with that, I will wrap up and thank you for your attention.